Thank you, Arvin. Well, it's good to be here. Got through some technical difficulties. I'm starting a little behind, so don't hold it against me if I go a few minutes over, but I will probably try and speed up a little bit to see if I can get us on time. This is a talk on follicular lymphoma. If people have heard me give talks before, people might be well aware that I like to sprinkle in a bunch of jokes and funny cartoons, but this version they got eliminated for some reason, so I'm going to spare you with some of that, which is a good thing. And you know, when I was asked to do the talk, I was thrilled to do it, and I still am, and I really want to, thank Binay and Arvind and the opportunity to be here to speak. But I didn't really realize that even though today is the first preseason Seahawk game, that it would overlap exactly with my talk. So I'm a diehard Seahawk fan, so this is very difficult for me. So if I pull out my phone just to see what's happening, don't hold it against me. The disclosures, and of course you saw this slide by Dr. Venetoclax just a few minutes ago. We're focusing on the indolent lymphomas on the right side of the screen here. These are of course the lymphomas that patients might have for many months. They may present feeling perfectly well. They're asymptomatic. They have a lymph node perhaps that's been around for a little too long, and it ends up leading to a biopsy that shows a disease that we call an indolent or slow-growing, relatively speaking, non-Hodgkin lymphoma. And all those are the major ones in that subgroup of indolent lymphomas are noted in the red. We'll focus mostly on follicular lymphoma, but probably what we're saying for follicular could hold true for small lymphocytics for the large part, MALTs, lymphoplasmacytics, and the like of the indolent lymphomas. Well, it's 2016, right? And we have all these great new drugs, and you heard about a couple of them in the last presentation. What should we be doing now with all of these new drugs, and how should we be incorporating these into having major impacts and outcomes for patients with indolent non-Hodgkin lymphoma? And one of the questions that's commonly asked is there still a role for watch and wait for these patients? And sadly, the answer is yes, there is still a role. And in fact, still that is the right thing to be doing for patients who don't have an indication or need for treatment. We don't have great data, nothing very recent, of course, but if you look at the National Lymphocare study, which this was, tried to compare outcomes a little bit for people in the front line who get treatment or just start with watch and wait at the time of diagnosis. Certainly, there are factors that led us to saying for the patients who watch and wait that we would want to do that. Those are typically patients that don't have symptoms, they've got an excellent performance status, they don't have unusual presentation, and they're doing quite well. And if you look at patients who get active therapy compared to the watch and wait, again, this is not an accurate comparison of the way to do it, but not surprisingly, progression-free survival, if you treat somebody, is going to be better than if you don't. That's a no-brainer. Certainly same for treatment decisions. If you get therapy, you're going to go longer before you need therapy as opposed to someone who doesn't get treatment. That all makes sense. However, the most important part of this slide is at the bottom there. There's no difference in overall survival for these patients. So don't treat people unless you have to. Even in 2016, in this era of all these new drugs, watch and wait is still very appropriate. So here's my attempt at a case. Vinu, maybe I'll do better. This is a follicular lymphoma case of a 66-year-old attorney. I'm not sure what that attorney part means, but I thought it sounded good. And has fatigue and night sweats, fevers, symptoms, not doing well in that regard. So a little bit of adenopathy on exam, spleen's a little big, easily palpable. Largest lymph node on scan is about 3.5 centimeters. Performance status is, okay, but still having these symptoms, and it's ECOG of 1. The labs are there. LDH is just slightly elevated. Biopsy is done. This patient has a grade 1 follicular non-Hodgkin lymphoma. Bone marrow is involved, which is obviously common in this setting. So this patient obviously has stage 4 disease. So symptoms in their 60s, with a moderate amount of disease and stage 4. And so what do? I don't know if the response system is going to work or not. I'm getting a shake of the head that it will, so we'll try it. And it's A, B, C, D, or E. And unfortunately, I probably could have put F, G, H, I, and J on, but we just did a few. So whenever you want to advance it, if you can. If not, I don't know how that works. Okay, well, oh, I advance it. No, I don't, actually. No. Okay, well, that's all right. Am I missing anything?
No, there's supposed to be a timer up there.
Well, I just put my self-imposed timer on there, and so the time's up. So what's the answer here? Well, the answer could be any of these things, although this patient needs treatment, right? He's got symptoms, moderate amount of disease, not feeling well because of the ICAHO performance status. So watch and wait's probably, we're probably over with that for this patient, but you could choose any of these things, R-CHOP, RCVP, Bendamustine, Rituximab, and I don't know what other is, but we'll talk a little about that as we move forward, perhaps. Why would we choose any of those regimens? Well, they're all okay because nothing's been definitively proven as vastly superior than everything else. Of course, we like to use these drugs, and in particular in the United States, the most common regimen in this situation is Bendamustine and Rituximab, still in 2016. So this is, of course, based on the famous Rummel trial where we randomized patients to R-CHOP or Bendamustine and Rituximab in the upfront setting. And you can see, if you look at the progression-free survival for these patients, I'm not sure, I can't do anything about that little square up there, can I? On the upper left. That's the polling system that's working so well. Okay. And you can see that Bendamustine and Rituximab had a significantly improved progression-free survival, about a 40% reduction in the risk of relapse, progression, or death compared to R-CHOP. However, what we learned is that the overall survival was no different in these patients, and in fact the side effect profile, and particularly the degree of myelosuppression and the infections, were slightly greater in the BR arm. So either one of these approaches are certainly still reasonable, but Bendamustine and Rituximab has largely become the most commonly used regimen in the upfront setting for these patients. But not everybody is going to be anxious to get Bendamustine and Rituximab. Not everybody's anxious or even eligible or reasonable to get R-CHOP, as you know, and we need to be thinking about better regimens for these patients. And that's led to this regimen that Dr. Venetoclax mentioned in the large cell lymphoma study, and that's being looked at in indolent lymphomas as well, of using R-squared therapy. Now this is just Revlimid and Rituximab, or the R-squared, and it's been looked at in the relapse setting. John Leonard is published on that with a very, very good response rate in pre-treated patients. And now it's been looked at in early phase studies in the upfront setting with good, excellent response rates to this just dual agent doublet of response rates in the 90%, with pretty impressive CR rates as well. And this was led primarily from the MD Anderson group by Nathan Fowler, where he looked at lenalidomide and rituximab in combination for these upfront patients. I'll just point out that these are patients with median age in this trial of 110 patients of only 58, but some patients up in their 80s. So this is a regimen really where we're starting to think that might be very appropriate for people who are a little bit older and not going to be tremendous candidates for standard chemoimmunotherapy. These are patients primarily with follicular lymphoma, the majority with intermediate or high risk IPI scores, certainly need for treatment, advanced stage disease, elevated LDH, and about a third in some bulky disease as well. And again, just to reiterate what this looks like in all these other indolent subtypes, including a small number, but of 46 patients of follicular lymphoma, with now 98% of patients to this doublet getting a response, with the majority of those patients getting complete remissions. And those complete remissions are real complete remissions. Pre-treatment PET positivity was 98% of patients. After treatment with R-squared, it was PET negative in 93% of patients. So a very effective way to treat patients, hopefully with a relatively good toxicity profile. And in fact, the major thing that we see with this combination is a problem with the rashes, and so we need to, of course, think about ways that we want to continue to improve on reducing that risk, but certainly it's a risk that seems to be relatively well manageable. And that's shown here. In the upper right is follicular lymphoma, looking at progression-free survival. Excellent from this upfront initial first-line therapy, with at least 80% of patients alive and progression-free out now over 4 years, in fact, approaching 5 years. So very encouraging data in the indolent lymphoma category of using R-squared therapy. Well, of course, that's not the end of it, right? We have lots of new drugs that we want to think about using in follicular lymphoma as well. Here's a small little list of many of them who you might know about, you've heard about today, and you'll continue to hear about. I'll focus on a few of them. In the interest of time, I won't focus, obviously, on all of them. But why explore these novel agents? What's something that the driver for this? Well, of course, we want to understand the biology and use the biology to really drive the therapy. And the therapy, we want to be centered on that biology to be targeted such that we can deliver therapy to sites of disease and hopefully limit it to the amount of normal tissues that the drug would be exposed to, and thus hopefully make it a more tolerable therapy. And in this way, we hopefully can recruit and use the body's own immune system in a more effective manner to hopefully reduce relapses and lead towards curative therapy for patients with indolent lymphomas. And we can talk about cure here at the end, perhaps. Remember that one of these agents that's being actively explored is this agent here that you also heard about, incorporated in high-risk diffuse large cell lymphoma, but well-known in the CLL world of ibrutinib. It's a Bruton's tyrosine kinase inhibitor, and of course, since this is important for B-cell signaling, it makes sense to look at it in indolent lymphomas. Certainly, it is got activity in relapse setting. I'll show you that, but now the idea is that people are starting to explore it in further combination in the upfront setting for these patients with follicular lymphoma, as I mentioned. Here was a trial led by the Alliance, and it looked at R-squared in combination with ibrutinib, so lenalidomide, rituximab, and ibrutinib. Well, why not just add all three, a dose escalation, right? Well, I don't know if this was such a good thing. It was a reasonable approach. It certainly good response rates, excellent CR rates, but not dramatically different. In fact, really not different at all than what we just showed with lenalidomide and rituximab alone. Certainly it's a reasonable approach, but you're committing people to being on this pill for an indefinite long period of time, and I'm not sure that that's really required with these kinds of results. But that may lead to the idea that, well, once people do progress, and they will progress, maybe we should be thinking about using this as a single agent, which I'll mention. Okay, let's come back to our patient. So remember that our patient was 66, had all those symptoms, wasn't feeling perfect, and ended up getting bendamustine and rituximab. Got 6 cycles of the regimen, did very well, but unfortunately it didn't last long enough. And we see this, right? We hope to have those remissions that last, 6, 8, 10 years, but we're always fraught with the difficult patient who has an 8 or 10 or 12-month remission. So here's an 8-month remission with some adenopathy, spleen's a little big again, and it's confirmed on CT scan. Another biopsy was done. It confirmed again grade 1 indolent follicular non-Hodgkin lymphoma with marrow involvement as well. So had received bendamustine rituximab. Let's assume the patient needs treatment. The patient's progressed enough. What do we do? It's R-CHOP. Should we be thinking about some chemoimmunotherapy and hematopoietic cell transplantation, an autologous transplant? Should we be thinking about idelalisib, ibrutinib, or some other agent? Since I don't think it's going to work, I think we'll move on and we'll come back to the answer as we go through. So we're trying to figure out what to do for this patient. Of course, none of those approaches were particularly wrong. In fact, that's one of the problems with this disease. Nothing's wrong. Everything's right, and you could always justify that. In many ways, that's a good thing, but it also tells you that we have a long way to go before we establish a true standard of care. And it's different for each individual patient. We need to be thinking in relapse settings about problems with transformation. So those are, of course, people who have very unusual relapses with extranodal disease, typically very high LDH, people with rapid relapses as well, and symptoms. And that might necessitate another biopsy in many cases. Should we give anthracycline? As the patient already had anthracycline, it's still considered probably the most active drug in non-Hodgkin lymphoma and something we always have to think about. How fast is the disease growing? How old is the patient? What are the comorbidities? Is this bulky disease? What are our long-term plans as well? Is this patient a stem cell transplant candidate down the road? And we have to always consider what myelosuppressive therapy will be like on the ability to collect stem cells in the future. So I would say if you go back to the last slide, you could have probably done any of these things. I think it's a little premature to give this patient a transplant. Did relapse within 8 months. Certainly that's a bad sign, but we have all these new drugs. We should be thinking about something else for these patients if we can. So this patient had a common problem, a common thing that we see is failed bendamustine rituximab and gets R-CHOP. So R-CHOP was delivered in the second line, but this is another common scenario that it doesn't last too long. So they failed a chemoimmunotherapy regimen, and nominally switching to another one typically isn't a home run. It's associated here with an 8-month remission, and then symptoms come back, the marrow's again involved, has adenopathy, and now actually the patient's got a platelet count that's only in the 60s, partly perhaps because of some of the therapy that the patient's got. So now we're very quickly having to think about what we want to do for this patient at this time. And here's some choices, and again, the other category could be 10 or 15 or 20 different agents probably. Would you give chlorambucil and obinutuzumab? How about now salvage chemoimmunotherapy and a stem cell transplant, again, autologous? Or should we be thinking of a targeted therapy like Idela or Ibrutinib for these patients, or something else? So if you were going to vote, you would do that, but let's just move on because it's not clear how that's working. So I'll come back to this, what the answer is, but again, I'm not sure there's always a right or wrong answer, but now may be a nice time where we would think about giving something that's more of a targeted agent. And I'll mention idelalisib, and I know it's not a new drug, but remember it targets PI3 kinase, the delta isoform, in the B lymphocyte. It's important for B cell signaling. And of course, when we interrupt that pathway, as we would with targeting BTK with ibrutinib, we inhibit proliferation and induce cell death. So idelalisib has been looked at as a single agent in relapsed follicular lymphoma patients as well as small lymphocytic lymphoma patients who had failed at least 2 prior therapies. This was a trial that really tried to look at patients who we thought were not chemotherapy candidates, and you can see an overall response rate of about 58% when we take all patients, with a very small number of complete remissions, but somewhere around 10% or so can get complete remission to this oral targeted therapy. So it can, if you look at the obligatory waterfall plot, you can see that the majority of patients will achieve at least partial remissions, have good reduction in lymph node mass, not just in the follicular lymphoma patients, but also in the small lymphocytic patients. And in fact, it can actually provide a significant benefit for these patients that's not a chemotherapeutic agent. Remember, this patient had a platelet count of 65,000, so we have to maybe think about that when we want to figure out how to treat him. Here now we're getting progression-free survivals of around 12 months at a median for these patients. We want to do better. Maybe combinations will lead to that, but it's certainly an option for patients that we should keep in mind. This is an approved drug. It's the actual only targeted approved drug that we have in relapsed follicular lymphoma at this point. The problem, of course, is that it also is going to lead to relapses. We know that. This patient got started on idelalisib, single agent. It's 150 milligrams twice a day, got a partial remission with lymphocytosis very early on. That's what we would expect to see. And unfortunately, though, at 9 months, this patient developed severe diarrhea, 7-8 times a day. So what do you do to deal with this patient's diarrhea? Well, you have a lot of choices. One is you could just continue, and of course, maybe you change the diet and rule out infectious causes. You might hold the drug, use antimotility agents, or you might hold idelalisib and start systemic steroids or even topical oral GI-related steroids. And the answer here is 3. And I put this slide up for a specific reason, is that is the absolute right answer and important to know about your use of this drug. It can cause an inflammatory diarrhea. It happens late. You'll probably hear more about this from Dr. Kipps in a few minutes. It is certainly something that can be very significant. Grade 3 diarrhea is 7 or 8 stools a day or being hospitalized. If you've got an older patient, easy to get dehydrated, I'd highly recommend that you stay on your toes. And if you see this, you treat very aggressively, very early with systemic steroids. And it can actually take a good couple of weeks of steroids before it goes away. It's something to very, very much know about. In fact, I would really encourage you, if you ever use idelalisib, it's a good drug, but we need to make sure that we're very versed in not only understanding the side effects, but making sure our patients understand it as well, so they are very in tune and they tell us what to do when there is a problem. And it's not just diarrhea. Remember, there's 2 other major side effects to know about. One is you can get a transaminitis. It's always reversible. It can happen early. It's usually not a major problem, but the other thing that happens very rarely that you want to know about is a pneumonitis. It's kind of a non-infectious, insidious dry cough, perhaps some slight hypoxia, and it's again inflammatory and it's treated with steroids. So here's a little information again on the idelalisib-related diarrhea. There are 2 types. There's an early diarrhea that can happen in the first couple of months. It's treated with anti-motility agents. It's self-limiting. People do fine. What I just talked about in our case is this late diarrhea, 7, 8, 10, 12 months later. I had somebody develop very severe diarrhea after being on the drug for over 2 years. So it's something just to remember, and it's treated again with steroids. Okay, so what about ibrutinib if we don't want to deal with the steroids or the pneumonitis or the transaminitis? Why not just use single-agent ibrutinib? Well, it's been looked at, of course, as a single agent in phase 2 trials. It here shows you it can give a progression-free survival of about 50%, so, and an overall survival in the relapse setting that's quite good. But of course, these patients largely are going to do well no matter what we use. You can induce improvements in reduction in lymph node burden, shown here. Very, very few patients getting complete remissions, but partial remissions are not unheard of. But the single agent activity is relatively modest, especially even compared to the idelalisib, where there was about a 60% response rate. Here with ibrutinib, it's around 28%. Again, I mentioned 50% 1-year progression-free survival, which can be meaningful. It's very well tolerated. We do need to recognize, however, that ibrutinib has side effects that are not trivial, and we need to be on our toes for them. They're atrial fibrillation, any potential bleeding as major side effects, and then hypertension is not uncommon, happening in about 10 to 15% of patients as well. Well, of course, ibrutinib by itself isn't the story, right? Nothing is ever the story until we add rituximab to it. And that's what Nathan Fowler's done here in this study of treatment-naive from patients, now combining ibrutinib with rituximab. In the interest of time, I won't go through this, but again, reiterate that this could be a nice regimen for patients who are a little bit older if we can actually confirm with some further studies that this would be an appropriate therapy. But the early data here suggests that this is encouraging. You can see here the waterfall plot. Again, quite encouraging reductions in tumor burden, and response rates are now excellent, or improved, I should say, with the addition of rituximab to the ibrutinib. Response rates of around 80%. Actually now with getting complete remissions, around 1 out of 3 patients, or 30%. So significant improvements by adding the rituximab to the ibrutinib. But again, the problem is that it doesn't last long enough. So median times here of getting improvements in progression-free survival are relatively limited, and people continue to relapse. We'll have to follow these patients for a longer period of time, but it's still very encouraging, with about 85% of patients at 1 year still alive and progression-free. Well, let's switch gears just for a minute and talk about the other new player on the block that you're well aware of, called Venetoclax. Venetoclax has just recently been approved. Tom and I and others were involved with its approval in CLL. And I won't tell you a lot about that because this is a follicular talk. You'll hear more about that perhaps in a little while. In the in the follicular world, however, we've looked at the use of Venetoclax for these patients. I will just say this is looking at patients who are treated with indolent lymphomas, or actually including large cell lymphomas. We treated a fair number of those patients, as well as patients with mantle cell lymphoma. And one of the things that we know about this drug is that it's very important to provide a slow dose escalation of the drug to ensure its safety. It's a very potent drug. I should have mentioned it's an oral agent. It's a BCL2 inhibitor. It's approved for 17p deletion CLL. It's not approved in indolent lymphomas at this point. But we do know that it can kill cells, and kill cells very rapidly, and the major side effect that we watch for is tumor lysis. Tumor lysis can be very rapid and very robust. One of the ways to attempt to mitigate that is this slow dose escalation, which you'll want to know about whenever you use the drug. It's not just, of course, knowing about this dose escalation. It's also important to know you have to watch the patient very closely when you start using this drug, and watching the electrolytes are incredibly important. But it's an important drug. It's an important drug because it has tremendous value of controlling disease, but not just controlling disease to provide remissions. Here you can see, here it just tells you a little about the patients, follicular lymphoma patients in particular. Now we're seeing patients in their upper 80s perhaps are even treated. Actually, I've personally treated a patient who was 92 with this drug. So it's been very well tolerated in that way. You can see the number of prior therapies, the degree of bulk, how many had elevated LDH here as well. And what was shown in these patients, and focusing here, of course, on the indolent follicular patients, heavily relapsed patients, heavily pretreated patients, relapsed multiple times, now having about a third of patients, small numbers, but having a response to the single agent Venetoclax. And the other thing that's important to note is that this single agent, as opposed to the other B-cell signaling agents that are targeted therapies that I've already mentioned, this one can provide complete remissions. Not a large number at this point. We need to continue to provide combinations to do that, but this drug can provide complete remissions, and actually we have data that shows that it can also eliminate minimal residual disease in the bone marrow, or in the bone marrow for these patients. This just shows you in the lymphoma setting, the folliculars in green, the waterfall plot can have significant responses. I'm not supposed to too much talk about large cell or aggressive lymphomas, but even some activity there. And actually we'll learn more about how to use this drug in lymphomas as we move forward. We need to think about combinations, because despite this encouraging data, again, heavily relapsed patients, the follicular lymphoma median progression-free survival is only, again, about a year. And as I mentioned, it's a very, very well-tolerated drug, but the major problem is tumor lysis. So it's important to keep that in mind when you're thinking about using this agent, and in particular thinking about it, using it in patients with bulky disease or very high white blood cell count, where the risk of tumor lysis is significantly greater. Lastly, I'll just close by this idea about, well, what would a talk be in lymphoma, or perhaps in any part of oncology, if we didn't talk about checkpoint inhibitors and immune blockade. Certainly there's a role for that here as well. And I won't really belabor this idea of checkpoint inhibitors, because everybody here knows that it's a way to take the brakes off of T cells by interrupting that PD-1, PD-L1 interaction between the tumor cell and the cytotoxic T cell. Lots of checkpoint inhibitors in development. You'll hear more about them as we move forward, of course. Nivolumab and Pembro are, of course, very widely used now, and in particular in relapsed Hodgkin lymphoma in the heme world, certainly being explored actively in relapsed refractory follicular lymphoma as well. A variety of others. Avelumab is a new one that actually still maintains the ADCC portion of the study of the antibody for targeting. And then lastly, a little data on this real quick. I'm getting the hook to come off the stage, forgive me, but looking at small numbers of patients, nivolumab, just heavily relapsed patients, just showing you that we do have some activity. Again, very small numbers, but some people perhaps even getting complete remissions to the checkpoint inhibitor. The follicular lymphoma patients are in the green here. You can see this is just a way to look at changes in disease burden over time, and you can see not everybody has a response, but certainly some encouraging things that we can work with. And we do know about the side effects of these drugs. In particular, we watch for pneumonitis, inflammatory problems like rash, and diarrhea as well. Just lastly, now another combination, right? PD-1 inhibitor plus Rituximab. So small numbers of patients, but now adding Rituximab and a heavily relapsed patient population getting good complete remissions, or at least reasonable, I should say, something for us to build off of and continue to do better. And looking at the progression-free survival for these patients, now we're actually up at about a year and a half or so in patients who have failed pretty much multiple other lines of therapy. So let me just give a little bit of a conclusion. Sorry to be over time. Lots of new agents. Kinase inhibitors are very important. I think they're great to remember in these patients where they can't tolerate standard chemoimmunotherapy, or you don't want to do a stem cell transplant. Perhaps that wouldn't be curative anyway and only incur toxicity. We still need to be thinking about combinations, and we need to be exploring those trials. And maybe we're, through immunotherapies, targeted therapies, these other agents, working towards eliminating the use, or reducing the use, I should say, of standard chemotherapy regimens. And lastly, we have a long way to go. Lots and lots and lots of unanswered questions. Really, is this whole thing that we've talked about, the research data that we've seen, actually practical in the clinical community setting? And really, we need to figure out ways to really define why patients are failing these drugs and how to overcome them. And we need to think also about how to sequence these drugs. Can we switch classes? Do these drugs need to be used indefinitely? When can we stop them? How can we achieve minimal residual disease for these patients? And how do we overcome, most importantly, perhaps, resistance for these patients? Okay, that's it for me. I'm sorry if I spoke a little long, but appreciate it.
John?